emergency calls for patients? I mean, as a retina practice, I'm sure you deal with emergency calls all the time.
Yes, ma'am, we do indeed. So it's always a challenge, you know. I think the big challenge, of course, is the flashes and floaters, the retinal detachments, you know, the endophthalmitis, the very urgent things that need to come in. So what we've done in our practice is we work very closely with our physicians to see what they want. And I think this is probably true across ophthalmology. If your physicians are nervous and anxious about certain diagnoses, you should get those people right in there. And that's sort of what we've done. So our front desk staff know if somebody's calling with endophthalmitis, it's, you know, how soon can you get here, essentially? And that's how we handle that. If it's flashes and floaters, you know, we talk to the physician if we're uncertain if we can get the patient in on that day, if it's fine for them to come the following day or what have you. But we work very closely with our physicians, and I've been doing this job for 20 years, and it feels like a terrifically long time. But I've learned through that I can pretty much predict what my physicians want and be able to handle it that way. And if I'm uncertain, I go to them or go to one of the techs to get some confirmation so we can be sure that we're handling those emergencies in the appropriate way. Um, you know, we often get calls of emergency nevuses. You know, we all know those aren't emergent. So we have to, of course, work with our referring doctors to make them understand that we're happy to see their patients, but, you know, we need those urgent slots for our truly emergent patients.
I know we have that too in peds. We'll have, there's keywords that the front desk should know. If somebody says this and they say it just happened, those are the things where like that's an emergency. When you're training your front desk, what is the time frames that you're looking at to say like, is this something that's been there for a while or this is emergent? It's like, I have to get you in now.
True. We have a little template that we use, and we have it at all of our front desks. And you know, if you have wet AMD and you're starting to see wavy lines, you know, we have a time frame for them to come in, and our doctors have established that. So we just follow that, and we try to follow that as best we can. And sometimes it's difficult, um, especially when the patient says, you know, oh, well, I can't come in next Thursday. I'm getting my hair done. And you're like, well, you know, maybe this is a little bit more important, and you need to get in here to get this taken care of. So there's a little bit of a challenge, I think, on both sides, you know, working with the schedules, but also working with the patients to make sure it's urgent. Sometimes we get calls from physicians and they'll say, I have a retinal detachment, they need to come in tomorrow. And our clever front desk staff will say, and how long has this been going on? And sometimes the retinal detachment's been there for 3 months. Well, I'm sorry, you don't need to be seen tomorrow. You know, it's been 3 months. The patient hasn't, you know, followed up on them with their primary care doctor or their primary ophthalmologist, what have you. We're not going to bend over backwards to see these folks either because it is truly not urgent. So there's a lot of, I always say to my staff, you need to be a good journalist, you know, who, what, when, where, why, ask all those questions. And many times then the truth reveals itself and it becomes clear to you if this patient needs to be seen urgently or not. And then of course you have those nervous Nellies, you know, those patients who are really anxious. And sometimes it's better to get those anxious people in to settle their minds. Otherwise, they're calling the office every hour with, you know, a change in their symptom. So that's a challenge too. And it's very much you know, a call that the front desk has to make. And I encourage them after the patients have been seen, look at the chart, see if you made a good choice. And then remember that for next time, you know, remember that, you know, if the patient's saying, oh, I had a shower of floaters, that's probably a pretty critical patient, you know, or if they're talking about a curtain, obviously those are the types of things we want to be listening for and asking about. And also we can use that language to set patients' minds at ease. So if they think they're going to lose their vision by tomorrow, you can say, well, how long has the floater been there? Well, it's been there for 3 weeks. Is it getting worse, staying the same, getting better? It's staying the same. It's like, well, then you don't need to worry, you know? So a lot of that is a judgment and a lot of it is learning what our physicians want us to say to patients. So.
And you had said, be good journalists. We always say document, 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 because we might say, okay, I can get you in today, but it's a different location than you're used to, and somebody doesn't want that. At what point do we have to say we've done all we can, and this was the patient's choice?
Absolutely. And we are big on making notes in our system. You know, offered the patient an appointment tomorrow, patient is getting her hair done, would prefer to come next week. You know,
Yeah.
we do all of that because many times our doctors will come back to us and say, this patient should have been here last week. And it's like, yes, but she was getting her hair done, and our doctors appreciate that we make those notes because, it's busy when you're answering phones and sometimes you can forget. So I tell the front desk, make the notes, and that way you're covering your behind and making sure that the doctor's malpractice isn't going to be affected by this. So it's all good.
Absolutely. And you're normally dealing with significantly more high risk patients than I am in a pediatric practice or in a general ophthalmology practice. Um, but anytime generally we hear like there's no vision, I don't have vision in the eye starting from
Mm.
this morning. Those tend to be our like urgent, get them in today patient.
But, it's interesting, Heather, because somebody can have an ocular migraine and have exactly those symptoms. So you have to ask the questions. How long
Yep.
has it been going on? They'll say, I lost my vision. And then you say, is it still that way? Oh, no, it came back 3 minutes later. It's like,
Yes,
oh, okay. If you hadn't have asked that question, you would have brushed that patient in for no reason at all. So,
it's true.
yeah, lots of good questions.
Well, thank you so much for that. My last couple questions for you are going to
Mhm.
be, if you weren't in retina for ophthalmology, what other specialty do you think would be of interest to you?
Ah, not ophthalmology at all, huh? That's a hard question. I'm married into ophthalmology, so it's really hard for me to not be in ophthalmology. I think I'd probably be in primary care. I think that's always fascinated me, just kind of learning about broadly about everything we do. But then, I'm a patient in a lot of orthopedic practices around here, so maybe that would be it. I don't know. One of those two.
And then what is one of your favorite things about AAOE?
Wow. I would probably say e-talk. E-talk has been just a vital lifeline for me. Like I said before, I started in ophthalmology 20 years ago, but I started somewhat under duress. My husband was opening a practice. He wasn't planning to. It just happened. And I kind of had to step in to help him. And I had worked in ophthalmology, but I had worked in Canada in the Canadian system, very different than here.
Mhm.
And I had a lot to learn. I mean, I knew a lot, but I had a lot to learn about how things worked in the medical office and how things worked with billing and things like that. And eTalk was really, I don't know, that extra person in my office for me to just ask a question of at any moment of the day or night, and somebody would respond with an answer that was very insightful and sometimes reiterated by 10 other people, so you knew it was a good answer. And that helped tremendously to build my confidence and to help me as I ran my practice. And I'm just amazed now, like all of the doctors, all of the staff in our office, they'll say to me, just ask them on eTalk. They'll know because they know what a resource it is and they know how much I talk about it because, really it helped me to be the administrator I am today, truly.
That's a perfect answer.